Welcome, curious minds, to another deep dive. Today, we're plunging into a part of the human body that is nothing short of a marvel, the thoracic cavity. Just think about it. Within our chests, there's this incredible interconnected network of vital organs, delicate structures, and complex systems all working in harmony. Understanding even a small part of it can unlock a world of knowledge, and you'll quickly see how every single detail matters in this intricate field. Okay, let's unpack this. Today we're taking a deep dive into the intricate world of thoracic surgery. It's a field brimming with fascinating anatomy, critical diagnoses, and life-saving interventions.
And to truly master the core concepts of chest anatomy, common pathologies, and the cutting-edge surgical approaches, our source today is foundational. Key excerpts from SCHWARTZ's Principles of Surgery. This is the definitive text in the medical community. It's packed with detailed information from the subtle vascular supply of the trachea to the nuanced management of complex lung diseases and chest wall conditions. Our mission, for you, is to distill this immense knowledge, helping you grasp the essentials like the elite professionals in this field do. We're going to get into the why behind the what to give you true understanding.
Exactly. Think of this as your shortcut to truly understanding the core concepts, those aha moments that make complex medical information accessible and memorable. You'll walk away with a profound appreciation for the human chest cavity and the incredible interventions that save lives, armed with a level of detail that will genuinely surprise you without, overwhelming you with textbook minutia.
Yeah.
So let's start with the very airway itself, the trachea. Here's where it gets really interesting, right at the microscopic level. Did you know that the trachea, this vital windpipe, has a very specific and delicate way it gets its blood? It's not a free-for-all where blood just floods in from all directions.
That's a great point to start with, because it reveals a crucial surgical principle. The trachea's vascular supply is remarkably precise. Think of it like a carefully planned irrigation system, rather than a wide river. Each tiny arterial branch that feeds the trachea only supplies a very small specific segment, just about 1 to 2 centimeters. This is incredibly important in surgery because it directly limits how much of the trachea can be safely mobilized around its circumference without compromising its blood supply.
Okay.
If a surgeon tries to move it too far, they risk cutting off the blood flow to that segment, leading to devastating complications. What's also fascinating is that these individual branches are interconnected along the lateral surface of the trachea by an important longitudinal vascular highway.
Okay.
This longitudinal pathway then feeds smaller transverse vessels that nourish the soft tissues between the cartilages. So any disruption, especially if it circles the trachea, can put that segment at severe risk. Precision is absolutely paramount here, more so than in many other parts of the body.
That makes a lot of sense. So given that delicate supply, what can actually harm this vital airway? It feels like it's tucked away, but it's clearly vulnerable to many different kinds of injuries.
Indeed, the trachea can be injured in a surprisingly diverse number of ways. You might think of obvious blunt or penetrating trauma to the chest or neck, which can crush or sever it. But more insidious causes exist too. For instance, the inhalation of smoke or toxic fumes can chemically burn the lining, and the aspiration of liquids or solid objects can cause direct trauma or inflammation.
Right.
A very common medical cause is endotracheal intubation, particularly if it's prolonged or the tube is oversized. Even during other surgical procedures, an iatrogenic injury, meaning an injury caused by medical intervention, can occur. The critical takeaway here is that early diagnosis of any tracheal injury is absolutely crucial. Delays can lead to severe complications. Imagine trying to breathe through a straw that's slowly collapsing. That's essentially what happens with tracheal stenosis, a narrowing of the airway that's a common long-term complication if injuries aren't addressed. It can also lead to serious respiratory infections. For non-traumatic injuries like smoke inhalation or aspiration, management is primarily supportive, focusing on keeping the airway clear and preventing infection. In very rare and severe cases where the distal airways and lung tissue are badly damaged, patients might even need advanced life support like ECMO extracorporeal membrane oxygenation, which essentially acts as an artificial lung outside the body.
One of the most concerning long-term issues discussed in our sources is tracheal stenosis, especially after intubation. What does that mean for someone who's had prolonged breathing support?
Post-intubation tracheal stenosis used to be a much more frequent and serious problem. Historically, a significant number of patients developed narrowing of the windpipe after being on a ventilator. But with the widespread use of low-pressure cuffs on endotracheal and tracheostomy tubes, the incidence is dramatically decreased. This is a testament to how small advancements in medical devices can have a huge impact on patient outcomes. However, certain factors still increase the risk. Prolonged intubation is a major one. The site of a tracheostomy also matters. Is placed too high near the first tracheal ring, or if a transverse incision is used instead of a vertical one, it increases risk. An oversized tube or a history of previous intubations also plays a role. Beyond that, patient-specific factors are important. Older age, being female, prior radiation to the neck or chest, long-term corticosteroid use, and underlying conditions like autoimmune disorders or severe reflux can all make someone more susceptible. Even a properly placed tracheostomy, despite all precautions, can unfortunately still lead to some scarring and mild stenosis. The goal is always to use the smallest possible tube, downsize it quickly when feasible, and favor a vertical incision to minimize damage. Now, the types of lesions you might see are varied. For an endotracheal tube, it's often a narrowing at the cuff site. For a tracheostomy tube, you can get narrowing where the tube enters the trachea, or at the cuff level further down. The segment in between can also become inflamed. Sometimes damage occurs to the subglottic larynx just below the vocal cords, and in the most severe cases, you can have a tracheoesophageal fistula, a direct, dangerous connection between the windpipe and the food pipe, usually at the cuff level.
If someone develops this tracheal stenosis, what are the options? Is it always surgery, or are there other ways doctors can manage this complex problem?
For benign tracheal stenosis, surgical resection is widely considered the primary and most effective treatment. The idea is to remove the scarred, narrowed segment and then reconnect the healthy ends of the trachea. Think of it like repairing a damaged hose pipe. You cut out the bad part and splice the good ends back together.
Oh, okay.
Typically, this involves removing a segment between 2 to 4 centimeters. What's critical is to remove all the inflamed and scarred tissue to prevent recurrence. Even if up to half the trachea needs to be resected, surgeons can often still rejoin the two healthy ends without putting too much tension on the repair. The ideal outcome is for the patient to be able to breathe on their own, right in the operating room or very shortly after. However, surgery isn't always an option. Some patients have significant other health issues, or their stenosis is simply too long for safe surgical repair. In these cases, we look at palliative measures to improve breathing. Endotracheal stenting, often using silicone key tubes, can provide symptomatic relief by holding the airway open. But a significant caution exists against wire mesh stents, which have a known risk of eroding through the airway wall over time, a truly dangerous complication.
Wow.
Other less common alternatives include balloon dilation, laser ablation, and tracheoplasty, but generally their long-term efficacy is often marginal compared to definitive surgical resection.
Our sources also discuss a very specific and emergent complication, the tracheoinnominate artery fistula. This sounds incredibly serious. What exactly is it, and what's the immediate action medical teams take when this happens?
The tracheoinnominate artery fistula, or TIF, is indeed a devastating and life-threatening complication. It's a full-thickness injury that creates a direct connection, a fistula, between the windpipe and the innominate artery, which is a major artery lying just in front of the trachea. While it can also involve the esophagus behind it, the immediate life-threatening emergency is the arterial connection to the airway, which causes massive sudden bleeding into the lungs.
Okay, so time is critical.
Absolutely. Prevention is key here, and it's achieved through careful cuff management of tracheostomy or endotracheal tubes, ensuring the pressure of the cuff remains below a critical threshold. This constant monitoring is especially important for patients on prolonged ventilation. When a TIF is suspected, often signaled by a smaller sentinel bleed, followed by a sudden massive hemorrhage into the airway, immediate emergency management is critical. The first desperate step is to rapidly hyperinflate the tracheostomy cuff to try and tamponate or plug the bleeding from within the airway. Simultaneously, direct pressure can be applied externally by pressing a finger against the patient's sternum, essentially compressing the innominate artery against the bone.
Right, okay.
Another technique involves using a bronchoscope to apply pressure directly onto the bleeding site. While these immediate measures are underway, an oral breathing tube is prepared and inserted, often replacing the tracheostomy tube to secure the airway from above. The airway is then suctioned aggressively to clear the blood. The definitive treatment requires emergent surgical resection of the involved segment of the artery. Crucially, this is typically performed without reconstructing the artery, to quickly control the hemorrhage. This rapid and aggressive intervention is vital given the extremely high mortality rate, if not immediately addressed.
Moving from the windpipe to the lungs, our sources provide a deep dive into lung cancer. It's far from a single disease. How is it categorized, and why is that important for understanding its complexity?
Understanding lung cancer truly starts at the cellular level. The lung has two main components: the tracheobronchial tree, which are the conducting airways, and the alveolar spaces, where gas exchange happens. The airways are lined by specialized cells, including ciliated cells that sweep mucus out, and goblet cells that produce mucus. These cells and the submucosal glands in the airways are where many lung cancers originate. Then you have the tiny air sacs, the alveoli, which have type I cells for gas exchange, and type II cells that can regenerate and produce surfactant. Before full-blown invasive cancer, they're what we call pre-invasive lesions. Think of these as early warning signs, changes that show a potential for cancer development. The term precancerous doesn't mean cancer is inevitable, but these high-grade dysplasias are a clear marker. One type is squamous dysplasia, which develops when normal airway cells transform due to irritants like cigarette smoke. The cells become abnormal in shape and arrangement. Another is atypical adenomatous hyperplasia, or AAH, a small lesion that represents an early step towards adenocarcinoma. With modern CT scans, we can often detect these as tiny, hazy, ground glass nodules.
Right.
Broadly, invasive lung cancers are divided into two main groups: non-small cell lung carcinoma, NSCLC, and neuroendocrine tumors. The distinction is critical because it dictates treatment. Immunohistochemical staining using antibodies to identify specific proteins on the cancer cells is frequently used to refine the diagnosis.
NSCLC is a term we hear often, but what exactly does it encompass, and how has our understanding evolved to be so precise?
NSCLC used to be a rather uniform term, lumping together different types like large cell, squamous cell, and adenocarcinoma. But our understanding has rapidly evolved, particularly with breakthroughs in molecular biology. We now know that these subtypes behave differently and, crucially, respond to different treatments. It's no longer enough to just say NSCLC. We need to know the specific cell type to tailor chemotherapy for advanced stages. This is a game changer for precision medicine.
Absolutely.
Let's take adenocarcinoma as an example. We used to have terms like bronchoalveolar carcinoma, but a new classification system helps us understand its progression from those tiny AAH lesions through adenocarcinoma in situ and minimally invasive adenocarcinoma to full-blown invasive adenocarcinoma. These stages are defined by how the cancer cells grow and spread. Adenocarcinoma is often found in the outer parts of the lung, frequently discovered incidentally on CT scans, unlike squamous cell cancers, which are typically more central. When the symptoms do appear, they usually come from the cancer invading the pleura or chest wall, causing pain. On CT scans, adenocarcinoma can appear solid, part solid, or as a hazy ground glass nodule. Interestingly, bubble-like lucency on CT, especially in smaller tumors, often suggests slower growth and a better prognosis. However, coarse, thick spiculations, sharp projections extending from the tumor are a poor sign, often indicating vascular invasion and nodal spread, which impacts survival. The amazing level of detail in modern classification is driven by the fact that even subtle differences at the cellular or genetic level can profoundly impact a patient's journey.
That level of detail and classification is remarkable. What are some of the key differences that stand out when we look at, say, mucinous versus non-mucinous adenocarcinomas, which used to be lumped together?
It's true, the new classification brings incredible clarity, almost like a forensic science for cancer. The distinction between mucinous and non-mucinous adenocarcinoma is a perfect example of how granular understanding empowers precision medicine.
Okay.
While both types are found in similar proportions in smokers, their radiographic appearance on CT is a key differentiator. Mucinous adenocarcinoma often appears as consolidation, almost like a pneumonia, and can spread to multiple lobes. Non-mucinous, on the other hand, frequently presents as that hazy ground glass attenuation we discussed earlier.
Right.
The cell type itself is different. Mucinous is filled with mucus-producing cells, while non-mucinous has cells resembling normal lung lining. But the real revelation comes with genetic mutations. For example, a KRAS mutation is very frequent in mucinous adenocarcinoma, seen in about 3/4 of cases. In non-mucinous adenocarcinoma, it's far less common. Conversely, the EGFR mutation, a hugely important target for specific drug therapies, is almost never found in mucinous adenocarcinoma, but it's present in a significant proportion, nearly half of non-mucinous cases.
Wow, that's significant.
It is. This is why this detail matters so much. Knowing this specific genetic fingerprint of a tumor dictates which targeted therapies will actually work, offering a truly personalized approach to patient care. This is a true game changer. Beyond adenocarcinoma, squamous cell carcinoma often arises centrally in the lung, leading to symptoms like coughing up blood, wheezing from airway obstruction, or pneumonia. Sometimes it forms a cavity due to central necrosis. Large cell carcinoma makes up 10-20% of lung cancers and can be central or peripheral. Special stains are needed to differentiate it. Then we have salivary gland-type neoplasms, which surprisingly can arise in the airways from submucosal glands, just like in your salivary glands. And finally, neuroendocrine neoplasms, or NECs, are classified from low-grade typical carcinoid to high-grade small cell carcinoma, SCLC. Typical carcinoids are slow-growing, often in the central airway, and rarely spread. Atypical carcinoids have higher malignant potential, linked to smoking, and spread more often. Small cell carcinoma, SCLC, is the most aggressive, growing rapidly and spreading early. It's notorious for causing paraneoplastic syndromes, which we'll discuss in a moment.
Let's talk about who's most at risk. The statistics from our sources are quite sobering, especially when it comes to smoking. Lung cancer is a major global health challenge.
It is indeed. Lung cancer remains the leading cause of cancer death in both males and females. The sobering truth is that most patients are still diagnosed at an advanced stage, meaning therapy is rarely curative. There are some interesting prognostic markers. Women tend to have better survival than men, as do younger patients. Historically, white individuals showed better survival, but this disparity disappears when access to advanced medical care is unrestricted, suggesting that access to care plays a significant role.
That's important.
Now, regarding smoking, it is a profound risk factor. Over 7,000 chemicals have been identified in tobacco smoke, with more than 70 known carcinogens. These chemicals mutagenically bind to DNA, inducing genetic mutations. But the most sobering insight here isn't just that smoking causes lung cancer, but that it fundamentally changes the entire respiratory and digestive tract, putting patients at risk for multiple other cancers down the line: oral, laryngeal, esophageal. It's what we call field cancerization, a crucial takeaway for understanding long-term risk.
Field cancerization, okay.
This means a detailed history and physical examination of all these organ systems are essential for these patients. The relative risk clearly shows the impact. A current smoker has over 15 times the risk of a never smoker. While quitting significantly reduces this risk over time, it never fully returns to that of a never smoker, underscoring the long-term impact. It's also vital to acknowledge that lung cancer does occur in never smokers, and in these cases, the disease often has different characteristics, which means our diagnostic and treatment approaches need to adapt.
Given these risks, screening becomes a critical conversation. What's the latest recommendation for lung cancer screening, and how effective is it?
Lung cancer screening has undergone significant evolution, driven by a landmark trial called the National Lung Screening Trial, or NLST. This trial showed a remarkable 20% relative reduction in lung cancer mortality in the group screened with low-dose helical CT scans compared to traditional chest X-rays. This was a groundbreaking finding, demonstrating that early detection can truly save lives.
Wow, 20%.
Yes, exactly. Following this, the U.S. Preventive Services Task Force, or USPSTF, now recommends annual screening with low-dose CT for asymptomatic adults aged 55 to 80 years who have a significant smoking history, specifically at least 30 pack years, and are either currently smoking or have quit within the past 15 years. Crucially, patients must be healthy enough to tolerate curative treatment, like surgery, if cancer is found. Screening stops once a patient hasn't smoked for 15 years, develops a life-limiting health condition, or becomes unable or unwilling to undergo surgery. The hope with this approach is that about half of all diagnosed cancers will be found at an early stage, offering a much better chance for a cure.
Makes sense.
Beyond these core recommendations, screening might also be considered for patients aged 50 or older with a slightly lower smoking history, 20 pack years or more, but with additional risk factors that push their lung cancer risk above a certain threshold. In all cases, the decision to screen is a shared one between patient and physician, weighing the benefits against the risks. However, screening isn't without its challenges. The NLST, while successful, had a notable false positive rate. This means some patients experience significant anxiety, undergo unnecessary invasive tests, and potentially even receive morbid procedures to evaluate a suspicious finding that turns out to be benign.
Okay.
The impact of these false positives on quality of life and cost effectiveness is still being studied, particularly as screening programs expand beyond controlled clinical trials. Establishing clear guidelines for patient eligibility and managing positive findings remains a key area for ongoing development.
Screening often identifies solitary pulmonary nodules. What exactly is an SPN, and how do doctors determine if it's something to worry about?
A solitary pulmonary nodule, or SPN, is essentially a small, suspicious spot found on a chest X-ray, or, more commonly now, on a CT scan. With modern, highly sensitive CTs, what looks solitary often turns out to have other tiny nodules nearby in about half of all cases. The key question for doctors is this spot cancer? The probability of it being malignant significantly increases with certain factors. If you're a smoker, your chance of malignancy is much higher, 50% or more, compared to 20% to 40% in never smokers. It's also more concerning if you're symptomatic, older, male, or have had occupational exposures.
Okay.
CT findings give us important clues. Benign features include small size and specific calcification patterns inside the nodule, like a central dot or popcorn appearance, typical of a harmless hamartoma. Stability over time, meaning the nodule doesn't change on follow-up scans, is a very strong indicator of benignity. On the other hand, malignant nodules are more likely to have spiculations, which are sharp, pointed projections radiating from the nodule, or a scalloped border.
Right.
Growth over time is a critical piece of the puzzle. Lung cancers typically have volume doubling times ranging from about 3 weeks to over a year. A lesion that doubles in size very quickly might be an infection, while one that stays the same size for a long time is usually benign, although some slow-growing cancers do exist.
Okay.
PET scanning is a valuable tool here. It helps differentiate benign from malignant nodules based on increased glucose uptake. Cancer cells are often sugar-hungry, showing higher metabolic activity. While PET scans are highly sensitive for detecting cancer, they can also show false positives if there's inflammation or infection, and false negatives for very small or slow-growing cancers.
So it's not foolproof.
Exactly. The general approach for SPNs, especially those between 8 and 30 millimeters, is a careful algorithm. Observe stable ones, use PET for suspicious ones, and consider biopsy if malignancy is still suspected, followed by resection if confirmed. For pure ground glass opacities, which tend to be slow-growing, longer-term annual follow-up might be appropriate.
Sometimes a new nodule in the lung isn't a primary lung cancer at all, but a metastasis from a different cancer. How do doctors distinguish these, and what's the approach?
That's a critical distinction, and it can be quite challenging, especially in a patient with a history of cancer. Features that suggest metastatic disease include multiple nodules, smooth and round borders on a CT scan, and appearing shortly after the original cancer. However, it's absolutely crucial to always consider that a single new lesion could be a new primary lung cancer, even in someone who has had another cancer.
Okay.
For example, patients with a history of head and neck cancers have over a 90% chance that a new solitary lung lesion is a new lung cancer, not a spread from their previous one.
Wow.
When it comes to pulmonary metastasectomy, surgical removal of metastases in the lung, there are key principles. The original cancer must be under control, and the patient must be fit enough for a major operation. All the metastases must be completely resectable, and there should be no cancer spread beyond the lungs. The goal is always to completely remove all visible tumors. If adjacent structures like the chest wall are involved, they're removed together with the tumor. Removing an entire lung for metastatic disease is rarely justified.
There's a debate here between two surgical approaches for metastasectomy, VATS and open thoracotomy. What's the controversy about missing lesions?
This is a really interesting and ongoing discussion in the surgical community. Back in 1996, a study by McCormack showed that using VATS, video-assisted thoracoscopic surgery, which is minimally invasive to remove lung metastases, might miss a significant number of lesions that were later found during an open thoracotomy. They reported a 56% chance of missing lesions if VATS was used alone.
That seems high.
It does. However, that study was done before the widespread use of modern spiral CT scanning, which offers significantly higher resolution and can detect much smaller nodules. Proponents of VATS argue that the superior resolution of today's CT scans makes those older findings less relevant. Recent studies have actually suggested that only about 18% of malignant nodules might be missed with VATS in the current era, or that outcomes are equivalent to open surgery regarding missed lesions. But here's the kicker. A definitive prospective study comparing the two approaches using modern spiral CT hasn't been done to fully resolve this dilemma, so the debate continues. Balancing the benefits of minimally invasive surgery against the theoretical risk of missing smaller, hard-to-find lesions.
Lung cancer often presents with a wide array of symptoms, which can be quite nonspecific and easily mistaken for other conditions. What are some of the key clues that might prompt someone to seek medical attention?
You're right, lung cancer has one of the most diverse presentation patterns of any human disease. Symptoms depend on the tumor type, its exact location, its biological features, and whether it has spread. We can broadly divide symptoms into those directly affecting the lung and those affecting surrounding structures in the chest.
Right.
Pulmonary symptoms are a direct result of the tumor in the lung. In order of frequency, these include a persistent cough, often from irritation or compression of an airway. Dyspnea, or shortness of breath, usually means significant airway obstruction. Wheezing suggests severe narrowing of a central airway. Hemoptysis, or coughing up blood, is typically just blood-streaked mucus and rarely massive, and it usually means the tumor is in a central airway. Tumors can also cause pneumonia due to airway blockage or even lung abscesses if the tumor tissue becomes necrotic and infected. Then there are non-pulmonary thoracic symptoms, which occur when the tumor invades or compresses structures surrounding the lung. Chest wall involvement can cause 3 types of pain: sharp, localized pleuritic pain if the tumor irritates the outer lung lining, deeper chest wall pain if it invades ribs, and radicular pain, which can radiate along nerves and even be mistaken for something like kidney pain. Pancoast syndrome is a classic example. A tumor in the very top of the lung that causes a specific set of symptoms, including severe shoulder and arm pain, and Horner syndrome, a drooping eyelid, constricted pupil, and lack of sweating on one side of the face due to nerve invasion.
Wow, that's very specific.
It is. Phrenic nerve palsy occurs when a tumor invades the nerve that controls your diaphragm. This can lead to referred shoulder pain, hiccups, and shortness of breath when you exert yourself, because one side of your diaphragm is paralyzed. On X-ray, that side of the diaphragm looks elevated.
Okay.
Recurrent laryngeal nerve palsy is most common on the left side, where the nerve wraps around the aortic arch. Invasion here leads to a change in voice hoarseness, a loss of tone, or a breathy quality, and often coughing, especially when drinking liquids.
Got it.
Superior vena cava, SVC syndrome, occurs when a tumor or swollen lymph nodes compress the SVC, a major vein returning blood from your head and arms. This causes swelling in the face and neck, prominent veins in the chest, headaches, and dizziness, all of which worsen when leaning forward. Other symptoms can include back pain from vertebral invasion or dysphagia, difficulty swallowing, if enlarged lymph nodes compress the esophagus.
Beyond direct tumor effects, the body can react in strange ways, sometimes even signaling cancer before other symptoms appear. These are called paraneoplastic syndromes, right?
Yes, that's precisely right. Paraneoplastic syndromes are fascinating because they are systemic manifestations of cancer that are not directly caused by the tumor's mass effect or its metastases. Instead, they result from the systemic release of tumor-derived biologically active materials, such as hormones or peptides, that travel through the bloodstream. What's remarkable is that these syndromes can produce symptoms even before the primary tumor causes any local symptoms, thus potentially aiding in early diagnosis.
Interesting.
Their presence, importantly, does not influence whether a tumor can be resected or what treatment options are available. If the cancer is successfully treated, these symptoms often abate, and conversely, their recurrence may signal that the tumor has returned. The majority of these syndromes are associated with small cell carcinoma, a high-grade neuroendocrine tumor. Let's look at a couple of key examples. One is hypertrophic pulmonary osteoarthropathy, HPO. This can be severely debilitating. Patients experience tenderness and swelling in their ankles, feet, forearms, and hands due to inflammation of the outer layer of the bone. You might also see clubbing of the digits, where the fingertips widen and nails curve. Aspirin or NSAIDs can offer temporary relief, but the definitive treatment requires successful tumor eradication. 2. Hypercalcemia. This is the most common paraneoplastic syndrome in lung cancer. It's caused by the tumor ectopically secreting a parathyroid hormone-related peptide. Symptoms include lethargy, confusion, nausea, and dehydration. If the tumor is completely removed, calcium levels typically normalize. 3. Lambert-Eaton syndrome. This is a rare myasthenia-like syndrome. It's caused by the tumor secreting antibodies that interfere with nerve-muscle communication, leading to muscle weakness, particularly in the legs, and gait abnormalities. Strikingly, these symptoms may actually precede any radiographic evidence of the tumor. Treatment is directed at the primary tumor, and many patients show dramatic improvement with successful primary therapy.
When lung cancer spreads, where does it typically go and what symptoms might that cause beyond the lung itself?
When lung cancer metastasizes, it most commonly spreads to the brain, bones, especially the spine, liver, and adrenal glands, and sometimes even the skin or soft tissues. Brain metastases are found in about 10% of patients at diagnosis, and another 10-15% develop them later. These can cause headaches, nausea, seizures, or weakness on one side of the body. Lung cancer is also the most frequent cause of spinal cord compression. Bony metastases are found in about a quarter of patients, primarily causing localized pain. Any new localized pain on the bone should prompt a radiographic evaluation. Liver and adrenal metastases are typically asymptomatic and usually discovered incidentally during routine CT scans for staging. And skin and soft tissue metastases can occur, presenting as painless lumps under the skin.
This is a lot of information for a doctor to process. How do they systematically evaluate a patient to determine the best treatment path?
You're right, it's a comprehensive process. The pretreatment evaluation for lung cancer patients focuses on three critical areas. First, precisely diagnosing and assessing the primary tumor. Second, thoroughly checking for any metastatic disease. And third, determining the patient's functional status, meaning their ability to physically tolerate the proposed treatment. A systematic approach to each of these ensures accurate staging and suitable treatment planning.
Okay.
Assessing the primary tumor starts with a detailed patient history, asking about any pulmonary, thoracic, or paraneoplastic symptoms. Imaging, particularly a contrast-enhanced chest CT scan, is essential to delineate the tumor, assess mediastinal lymph nodes, and understand the tumor's relationship to surrounding structures. MR can be used if there's concern for major blood vessel or spinal invasion, or if the patient has a contrast allergy. Symptoms like localized pain can often suggest that the tumor is invading adjacent structures like the chest wall or nerves.
Getting a tissue sample is key to diagnosis. What are the best ways to do that, depending on where the lesion is?
Obtaining a tissue diagnosis is the very first step for any chest mass. The approach varies based on the lesion's characteristics and location. For more central lesions, bronchoscopy can be used. A scope is inserted into the airways to visualize and biopsy the tumor or nearby lymph nodes. Its effectiveness varies depending on how close the nodule is to the bronchial tree.
Right.
For peripheral lesions, an image-guided transthoracic FNA, fine needle aspiration biopsy, is common. This uses ultrasound or CT guidance to precisely direct a needle into the lesion to get a sample. It's highly accurate for peripheral lesions, but there's always a small chance of a false negative, meaning if it's not definitively benign, further investigation might be needed. The most common complication is a pneumothorax, or collapsed lung, because the needle goes through the lung. Some advocate for video-assisted thoracoscopic biopsy, or VATS, as an initial diagnostic option. This is a minimally invasive surgical approach where a small camera is inserted into the chest. With VATS, a small nodule can be completely removed, or a core biopsy taken from a larger one. VATS also allows for simultaneous staging, as lymph nodes can be sampled and invasion of contiguous structures can be assessed.
Got it.
Finally, an open thoracotomy. A traditional open chest incision is rarely necessary for diagnosis, usually reserved for deep-seated lesions that couldn't be biopsied otherwise, or when mediastinal invasion needs direct palpation. Crucially, if an entire lung needs to be removed, a definitive cancer diagnosis must be made before that major surgery. Now let's talk about metastatic disease assessment. About 40% of newly diagnosed lung cancer patients already have distant metastases, which often means surgery for cure isn't an option. We start with a detailed history and physical exam, looking for new bone pain, neurological symptoms, or unintentional weight loss. Basic lab tests like liver enzymes and calcium levels can also give clues. For mediastinal lymph nodes, which are crucial for staging, CT scans can show enlargement, but an enlarged node is only truly cancerous in about 70% of cases. The rest are reactive. This is why histologic confirmation is mandatory before denying a patient surgery based on CT alone.
Mandatory, right?
Absolutely. PET scanning is more accurate than CT for assessing mediastinal lymph nodes. It helps distinguish malignant from benign nodes based on metabolic activity. However, even with PT-positive nodes, histologic verification is still required to avoid undertreatment, especially in areas where inflammatory conditions can cause false positives. For invasive staging, we have several powerful tools. EBS-guided FNA, endobronchial ultrasound-guided fine needle aspiration, uses an ultrasound probe on a bronchoscope to sample paratracheal and subcarinal lymph nodes. It's highly accurate and minimally invasive. Endoscopic ultrasound, EUS, similarly uses a scope through the esophagus to access different sets of mediastinal lymph nodes. Cervical video-assisted mediastinoscopy is a surgical procedure that provides tissue sampling of all paratracheal and subcarinal lymph nodes. It's particularly recommended for centrally located or larger tumors.
Okay.
For left upper lobe tumors, left video-assisted thoracoscopic lymph node sampling might be necessary for specific lymph node stations. The key message is to always pathologically confirm mediastinal node involvement before ruling out resection.
What about fluid in the lung cavity in a cancer patient? A pleural effusion should not automatically be assumed to be malignant.
Exactly. It can be due to various reasons like heart failure or pneumonia. If it's the only site of concern for metastatic disease, then pathologic confirmation is mandatory. A thoracentesis drawing fluid with a needle is the first step, but cytology, cell examination, only finds cancer cells in about 50% of malignant effusions initially. Sometimes, a minimally invasive thoracoscopy is needed to definitively rule out pleural metastasis.
This brings us to the staging system, which is how doctors categorize the extent of cancer. What is the TNM system, and how has it changed recently to provide a more precise picture?
The TNM staging system is fundamentally how we estimate the extent of the disease and predict a patient's prognosis. T describes the primary tumor, N for regional lymph nodes, and M for distant metastasis. The N status N1, N2, or N3 is based on a very precise lymph node mapping system using clearly defined anatomical boundaries.
Okay.
The American Joint Committee on Cancer, or AJCC, updated its staging system to the 8th edition in 2018, incorporating major changes based on data from over 77,000 lung cancer patients worldwide. For T staging, tumor size and local extension are much more granular now. For example, the T category now has designations for each centimeter up to 5 centimeters. Also, if a tumor invades the visceral pleura, the inner lining of the lung, even a small tumor, 3 centimeters or less, automatically jumps to a T2 stage, signifying deeper invasion. Synchronous primary tumors, 2 separate lung cancers at the same time, also get a specific designation.
Interesting.
N staging describes regional lymph node involvement. N0 means no regional nodes involved. N1 means involvement of nodes on the same side, close to the lung. N2 means involvement of lymph nodes on the same side of the mediastinum, the central chest, or nodes under the carina, where the trachea splits. N3 indicates spread of lymph nodes on the opposite side, or nodes in the neck.
Okay, N0, N1, N2, N3.
Exactly. M staging for distant metastasis has also been subdivided. M0 means no distant spread. M1A now includes separate tumor nodules in the other lung, or tumor on the pleura or pericardium, or a malignant pleural pericardial effusion. M1B indicates a single metastasis in a single distant organ, like one spot in the liver. And M1C means multiple distant metastases in one or multiple organs.
Okay.
These T, N, and M descriptors combine to define the overall stage classifications from early IA1 all the way to advanced IVB. Beyond this, we now record additional details like the tumor's grade, whether it's invaded blood or lymph vessels, the adequacy of surgical margins, and even the tumor's mutation status. This helps us refine prognosis and guide future research.
Got it.
For small cell lung cancer, SCLC, staging is typically simpler, just based on the extent of disease. Limited SCLC means the disease is confined to one side of the chest and can be treated within a single radiation field. Disseminated SCLC means the tumor has spread beyond that, often to the brain, bone, or bone marrow.
Even with a clear diagnosis and stage, surgery isn't always an option. Patient fitness is crucial. How do doctors assess if someone can tolerate major lung surgery?
Assessing a patient's functional status, their ability to tolerate major lung surgery, like a lobectomy or pneumonectomy, is paramount. The surgeon first estimates the likely type of resection needed based on CT images. Then, a systematic evaluation begins.
What are the key questions a doctor asks to gauge someone's risk? It sounds like simple questions can reveal a lot.
You're absolutely right. A patient's history is arguably the most important tool. Simple, direct questions about their functional status provide crucial insights. For instance, if a patient can walk indefinitely on a flat surface without needing oxygen and without getting short of breath, they are very likely to tolerate a lobectomy. If they can walk up 2 flights of stairs without having to stop to rest, they will likely tolerate a pneumonectomy. Almost all patients can tolerate single lung ventilation and a wedge resection, the smaller removal of lung tissue, unless they have very severe underlying lung disease. Beyond these, a formal assessment of cardiac fitness is mandatory, using risk scores that predict heart complications after surgery.
Right.
Current smoking status and sputum production are also highly pertinent. Current smokers and those with a history of very heavy smoking have a significantly increased risk of post-operative pulmonary complications. For every 10% decline in lung function, measured by carbon monoxide diffusion capacity, the risk of pulmonary complications increases by 42%. While it's ideal for patients to stop smoking at least 8 weeks before surgery to reduce risk, even 2 weeks of abstinence is encouraged. Paradoxically, quitting on the very day of surgery can sometimes increase sputum production and lead to retention issues. Patients with chronic sputum also have a higher risk for pneumonia and retention, so prophylactic antibiotics or bronchodilators might be needed. Pulmonary function studies, PFS, are routinely performed for resections larger than a wedge. The two most valuable measurements are forced expiratory volume in 1 second, FEV1, and carbon monoxide diffusion capacity, GELCO. While general guidelines exist, for example, an FEV1 greater than 2.0 liters for pneumonectomy raw values can be imprecise. The percent predicted value, adjusted for age, height, and gender, is far more crucial.
This is a clever way to estimate lung function after surgery. How is it calculated, and how does it help in predicting risk?
It's a key calculation using predicted postoperative values, PPO-FEV1 and TPO-DILCO. To determine these, we take the patient's existing FEV1 or DILCO percentage and multiply it by the fraction of lung that will remain after the proposed surgery. For example, if a right upper lobectomy is planned, which removes 3 out of 20 lung segments, the patient will be left with 85% of their original lung capacity. So if their preoperative FEV1 is, say, 30% predicted, their predicted postoperative FEV1 would be 30% multiplied by 0.85, resulting in 25.5%. A predicted value of less than 50% for either FEV1 or DILCO correlates with an increased risk for complications, with risk increasing for every 10% decline below that threshold.
Right, so it's a direct calculation.
Yes. Quantitative perfusion scanning is also used to estimate how much each part of the lung contributes to function, especially when a tumor partially obstructs an airway. For example, if a patient's right lung only contributes 21% to their overall perfusion, normal is 55%, and their FEV1 is 60% predicted, then after a right pneumonectomy, their PPO-FEV1 would still be a tolerable 47%. But if that same lung were contributing 55% to perfusion, then the PPO-FEV1 would drop to a high-risk 27%. Finally, exercise testing, VO2 max, is valuable when the patient's daily functional status seems better than their lung function tests suggest. VO2 max, which measures maximal oxygen consumption, provides crucial additional information. Values below 10 millkilogemin generally prohibit major lung resection due to a significantly higher mortality rate. Ultimately, the decision for surgery is an amalgam of clinical judgment, these objective data points, and the patient's own attitude and motivation.
Let's pivot to treatment. For small cell lung cancer, the approach is very different from NSCLC, isn't it?
Yes, for small cell lung cancer, SCLC, the treatment approach is indeed quite distinct from NSCLC. Surgery is rarely beneficial, typically only considered in very isolated instances where SCLC presents as a highly localized solitary lung lesion, and crucially, only after surgical mediastinal staging has definitively confirmed no spread to the mediastinal lymph nodes. These cases represent less than 5% of all SCLC diagnoses. For more advanced stage disease, surgical resection offers no benefit. The primary treatment for SCLC is chemotherapy, often combined with radiation therapy, with the specific regimen depending on the extent of the disease and the patient's overall performance status.
For early stage NSCLC, surgery is the gold standard. What types of resections are performed, and how do surgeons decide which is best?
For early stage non-small cell lung cancer, surgical resection is the current standard. Ideally, this is accomplished via video-assisted lobectomy or pneumonectomy, depending on the tumor size and specific location.
Okay.
Regarding resection types, the choice depends heavily on the tumor's characteristics. A lobectomy, which is the removal of an entire lung lobe, is the most common approach. A sleeve lobectomy is performed if a margin cannot be obtained by a standard lobectomy, involving resection of a portion of the bronchus with reanastomosis. Pneumonectomy, the removal of an entire lung, is rarely performed but indicated for large central tumors. With the recent evidence from screening CTs, there's renewed interest in limited resections, such as an anatomic segmentectomy or extended wedge resection, along with lymph node dissection. Studies suggest that carefully ensuring a surgical margin that is more than the tumor's diameter, along with thorough lymph node assessment, can significantly reduce local recurrence rates, achieving outcomes comparable to lobectomy. While these often require an open thoracotomy, increasing experience with VATS in high-volume centers shows that limited resection is safe and feasible.
Beyond traditional surgery, there are newer, less invasive options for early-stage lung cancer, especially for patients who might not be surgical candidates. What are these ablative strategies?
Tumor ablative strategies are increasingly being explored as viable alternatives, particularly for patients who are not considered operable due to other health issues. These techniques may eventually prove to have efficacy equivalent to lobectomy for very small peripheral early-stage lung cancers, potentially even becoming a primary therapy for operable patients. This evolution requires robust, multidisciplinary collaboration among thoracic surgery, interventional radiology, and radiation oncology to ensure these techniques are developed and applied effectively.
Makes sense.
One such method is radiofrequency ablation, or RFA. This is an excellent option for patients at high risk for traditional surgery or who refuse it. However, contraindications include lesions larger than 5 centimeters, tumors directly next to the lung's hilum, malignant effusions, or more than 3 lesions in one lung. Proximity to a large blood vessel is also an issue due to bleeding risk and the heat sink effect, where blood flow dissipates the heat needed to destroy the tumor. For these patients, stereotactic body radiotherapy, or SBRT, may provide local tumor control with less risk. SBRT delivers highly precise, high-dose radiation. Because the radiation field is so accurate, patients with severe emphysema can be safely treated without significantly worsening their overall lung function. However, SBRT for central tumors near the mediastinum has an increased incidence of complications like hypoxia and pneumonitis, so careful planning is essential.
Stage 3 lung cancer is a complex scenario with varying prognosis depending on how the cancer has spread. How is it approached, especially concerning N2 disease, meaning involvement of the mediastinal lymph nodes?
Stage 3 lung cancer, or locally advanced NSCLC, is indeed a complex and varied group. The overall 5-year survival is about 28%, but this average masks significant differences, from small primary tumors with mediastinal lymph nodes spread to very large tumors invading unresectable structures. Regarding N2 disease metastasis to ipsilateral, mediastinal, or subcarinal lymph nodes, the prognosis differs based on whether the N2 disease is bulky and clinically evident, or microscopic and incidentally discovered. For patients with bulky N2 disease, surgery alone has a very low 5-year survival rate. In contrast, those with microscopic N2 disease, found incidentally in a single lymph node after surgery, may have a much better 5-year survival rate. This distinction is so important that many surgeons and oncologists differentiate between the two, as well as the number of involved nodes when deciding on treatment. Histologic confirmation of N2 nodal metastases is absolutely imperative. False positive findings on PT scans are unacceptably high, especially in regions with many granulomatous diseases, leading to undertreatment if not confirmed. If N2 nodes are found incidentally during surgery, the surgeon might continue with resection or stop and refer for induction therapy. When confirmed N2 metastases are found before surgery, patients are typically referred for induction chemotherapy. If the nodes are sterilized, cancer eliminated by chemotherapy, surgical resection is generally warranted as part of a multimodal approach.
Pancoast tumor sounds like a particularly challenging type of lung cancer due to its location. What makes it so unique, and how does the treatment account for that?
Pancoast tumor is indeed unique and challenging. It refers to a carcinoma arising in the extreme apex of the chest, specifically in the superior sulcus. This location leads to a very specific set of symptoms, including severe arm and shoulder pain, muscle atrophy in the hand, and Horner's syndrome, a constellation of symptoms like a drooping eyelid and constricted pupil due to nerve invasion. Treatment for Pancoast tumor is inherently multidisciplinary. Given the tumor's location and its frequent involvement of the neurovascular bundle supplying the arm, preserving the function of that extremity is critically important. For this reason, surgical resection should only be performed in patients who are proven negative for mediastinal lymph node involvement, no N2 disease. Survival is poor with N2 positive nodes and surgical morbidity is high. EBUs or EUS can help confirm nodal involvement if bulky, but a negative FNA is not sufficient and should always be followed by mediastinoscopy for accurate evaluation.
Chemotherapy before surgery, or neoadjuvant therapy, is mentioned. What are the benefits of this approach for lung cancer patients?
Neoadjuvant chemotherapy, or chemotherapy administered before surgery, offers several significant benefits. Firstly, it allows clinicians to assess the tumor's sensitivity to chemotherapy by observing its size reduction and microscopic necrosis. This gives valuable insight into how responsive the tumor is. Secondly, and very importantly, it can improve resectability by shrinking the tumor, potentially making a tumor that was initially too large or invasive for surgery amenable to resection. Patients whose tumors show a good response to preoperative chemotherapy generally have a much better prognosis than those with a poor response.
We talked about VATS for diagnosis, but it's also used for resection. What are the advantages of minimally invasive surgery over traditional open surgery, and for whom is it particularly beneficial?
Video-assisted thoracoscopic surgery, or VATS, and its robotic counterpart, RPETS, have truly become the recommended approaches for a wide range of thoracic procedures. Beyond diagnosis, they're used for treating pleural effusions, recurrent collapsed lungs, lung biopsies, and removing lobes or segments of the lung. In some specialized centers, these approaches are even used for removing an entire lung.
Okay.
The benefits of VATS over traditional open thoracotomy are significant and well documented. Patients experience significantly less pain, leading to an earlier recovery of respiratory function, improved overall functional status, and a quicker return to work. They also tend to tolerate subsequent chemotherapy better. These benefits are particularly pronounced in patients with chronic obstructive pulmonary disease, COPD, and in the elderly populations whose quality of life can be dramatically impacted by changes in respiratory symptoms and pain.
Right.
VTS may be preferable in several circumstances. This includes patients with compromised lung function, severe smoking history, heart dysfunction, other cancers, or those with poor physical performance or advanced age. When a thoracoscopic approach isn't possible, open approaches are used. The most frequent is the posterolateral thoracotomy, which provides excellent access for most lung resections, esophageal operations, and procedures in the back of the chest. The anterolateral thoracotomy is often used in trauma victims because it allows for quick entry into the chest, crucial for emergency situations.
After such major surgery, recovery is paramount. What's involved in postoperative care, especially with chest tubes and pain management?
Postoperative care after thoracic surgery is indeed crucial for a smooth recovery and minimizing complications. Chest tube management is a cornerstone of this care. After most operations, the pleural cavity is drained with chest tubes. Historically, tubes were left in until drainage was very low, but we now understand that the pleural lymphatics can absorb a significant amount of fluid, up to about 500 milliliters over 24 hours. Studies have shown that chest tubes can be safely removed with outputs as high as 400 milliliters over 24 hours without fluid reaccumulation. So current practice allows for earlier removal after most lung resections.
Okay, that's changed.
Yes. For pain control, effective strategies are vital to facilitate recovery and lung expansion. Epidurals, when properly managed, provide outstanding pain control without systemic sedation. While they can affect blood pressure, newer options like paravertebral catheters offer equivalent pain control with less effect on hemodynamics. More recently, liposomal bupivacaine has emerged as a promising new option. This formulation allows for a slow release of pain medication for up to 72 hours when injected directly into the intercostal spaces. While promising in retrospective reports, randomized trials are still needed to fully confirm its benefits and cost effectiveness.
Despite best efforts, complications can arise. What are some of the most serious ones after lung resection?
While good pain control and aggressive pulmonary care help, complications can still occur, ranging from minor to life-threatening. The most devastating complication after pneumonectomy, the removal of an entire lung, is post-pneumonectomy pulmonary edema. This happens in 1 to 5% of patients, more commonly after a right pneumonectomy. Patients develop respiratory distress hours to days after surgery, with fluid buildup in the remaining lung seen on x-rays. It's thought to involve increased permeability and pressure in the remaining lung, coupled with decreased lymphatic drainage.
Right.
Prevention is critical and involves very careful management of intravenous fluids during and after surgery, prioritizing blood pressure support with medications over giving too much fluid. Treatment includes ventilatory support, strict fluid restriction, and diuretics. It carries a nearly 100% mortality rate without aggressive intervention, and ECMO extracorporeal membrane oxygenation can be life-saving in severe cases. Other common complications include air leak and bronchopleural fistula. Postoperative air leaks are common after lung resection, especially in patients with emphysema, due to impaired healing of the lung surface. If a leak lasts more than 5 days, it's considered prolonged and can be managed by adjusting suction, continuing drainage, or instilling a pleurodesis agent like talcum powder to seal the lung to the chest wall, but only if the lung is fully expanded.
Okay.
A bronchopleural fistula is a more serious complication. A direct communication between the bronchial stump, where the airway was cut, and the pleural space. This is highly suspected if there's a moderate to large air leak, especially in immunocompromised patients. Flexible bronchoscopy is used to evaluate the stump. Management often involves continued chest tube drainage, or for very small fistulas, endoscopic application of fibrin glue. These fistulas are often accompanied by empyema pus in the pleural space, which may require open drainage.
Beyond surgery complications, what causes a lung to spontaneously collapse?
A spontaneous pneumothorax refers to a collapsed lung that occurs without any obvious external cause. Primary spontaneous pneumothorax typically affects thin, tall men aged 20 to 40, The risk of recurrence is quite high, between 30–50% within 2 years. Intervention is considered for a first episode if there's a persistent air leak, if the lung doesn't fully expand, or if it recurs. It's also considered for people in occupations like air travel or deep-sea diving, where a collapsed lung could be life-threatening. CT scans often reveal small air-filled sacs or blebs, which are linked to recurrence. Many surgeons now recommend VATS, minimally invasive surgery, to remove these blebs and create adhesion between the lung and chest wall to prevent future collapses, even for the first episode.
Right, even for the first time.
Yes. Secondary spontaneous pneumothorax happens when there's an underlying lung disease like emphysema, cystic fibrosis, or even lung cancer, which causes the collapse.
Okay.
A rare but interesting cause is catamenial pneumothorax, which affects women and occurs within 72 hours of their menstrual period, possibly related to endometriosis. Management for all types primarily involves draining the air to re-expand the lung, with additional therapy often tailored to the specific underlying disease to prevent future occurrences.
What happens when an infection leads to tissue destruction in the lung, forming an abscess? This sounds quite serious.
A lung abscess is essentially a localized area of lung tissue destroyed by infection, forming a cavity at least 2 centimeters in diameter. If there are multiple smaller cavities, it's called necrotizing pneumonia. If it's been there for over 6 weeks, it's chronic.
Okay.
They're classified as primary or secondary. Primary abscesses happen in immunocompromised patients or those prone to aspirating, inhaling mouth or stomach contents. Secondary ones occur due to an underlying condition like a blocked airway or a lung infarct. The microbiology is typically polymicrobial, meaning multiple types of bacteria are involved, often anaerobes from the mouth. In hospital-acquired infections, gram-negative bacteria are common. Immunosuppressed patients can get abscesses from less common organisms like salmonella or certain fungi. Clinical features include cough, fever, chills, and weight loss. After aspiration, it takes 1 to 2 weeks for a cavity to form, and the sputum can be foul-smelling. Serious complications like massive bleeding are rare now thanks to antibiotics. Rare but virulent infections like actinomycosis and nocardiosis can also cause lung abscesses and often mimic tuberculosis. They can be hard to diagnose and may require long-term antibiotics and even surgery if not caught early. Management primarily relies on systemic antibiotics for 3–12 weeks until the cavity resolves. Surgical drainage is uncommon because abscesses often drain spontaneously into the airways. However, surgery might be needed for very large cavities. Lack of response to antibiotics, suspected cancer, or complications like massive bleeding.
Bronchiectasis, a chronic lung condition, is mentioned as well. What is it and how is it managed?
Bronchiectasis is a chronic, irreversible dilation of the bronchi and bronchioles, resulting from ongoing inflammation and infection. Imagine your airways like branching tubes. In bronchiectasis, they're abnormally widened and often inflamed. It can be congenital, like in cystic fibrosis, or acquired from past infections like tuberculosis, or from bronchial obstruction.
Okay.
Patients typically have a chronic cough, producing copious, often foul-smelling mucus. Hemoptysis, or coughing up blood, which can be massive in about half of cases, is also a common symptom. Diagnosis is primarily made by CT scans, which show characteristic findings like dilated bronchi or a signet ring sign, where a dilated bronchus next to a pulmonary artery looks like a ring on a finger. Management focuses on optimizing airway clearance through chest physiotherapy. Bronchodilators are used if there's airflow limitation, and correcting any underlying causes is crucial. Acute flare-ups are treated with antibiotics. Surgical resection of a localized segment or lobe is an option for patients with persistent, severe symptoms not responding to maximal medical therapy, with the goal of preserving as much functional lung as possible. For end-stage disease, bilateral lung transplant may be considered. Surgery is also indicated for significant hemoptysis, although bronchial artery embolization is generally the preferred first option now.
Tuberculosis is a global health challenge. What are the key things to know about mycobacterial infections in the chest, including how they present and are treated?
Tuberculosis, or TB, is a widespread global problem affecting nearly 1/3 of the world's population. While death rates have declined, millions of new cases still emerge each year. HIV infection is the strongest risk factor for active TB. High-risk populations include the elderly, minorities, recent immigrants, and those who are homeless or immunocompromised. Surgery is increasingly required for patients with multi-drug-resistant TB who don't respond to medical treatment.
Okay.
In terms of pathology, primary TB infection often leads to a calcified lesion. Reactivation, which occurs in 10–15% of patients, typically happens when the bacteria multiply, often involving the upper lobes. Non-tuberculous mycobacteria, NTM, cause similar changes, but often have a poorer immune response. Clinical presentation varies. Most TB patients have lung disease, though it can spread to almost any organ. The initial infection often heals into a dormant phase. Definitive diagnosis requires identifying the mycobacterium in body fluids or tissues, with sputum examination being highly diagnostic.
Got it.
The treatment algorithm for TB typically involves an intensive 2-month phase with multiple antibiotics, followed by a longer continuation phase. For drug-resistant TB, long-term antibiotics, months to years, are required, and surgery like drainage or resection may be needed.
Fungal infections in the lung can be tricky. Who's most at risk, and what are some of the key types, and how do doctors approach them?
Fungal infections in the lung disproportionately affect immunocompromised patients due to organ transplantation, chemotherapy, or steroid use. However, some fungi are primary pathogens that can infect otherwise healthy individuals, such as histoplasma, coccidioids, and blastomyces in the U.S. Definitive diagnosis relies on direct identification of the organism or culture. New antifungal agents are effective, and thoracic surgery often plays an important adjunctive role. Let's look at pulmonary aspergillosis and aspergilloma. An aspergilloma, often called a fungus ball, develops when the fungus Aspergillus colonizes a pre-existing lung cavity. Asymptomatic cases are often observed. While massive hemoptysis used to be an urgent surgical indication, bronchial artery embolization is now an effective first-line therapy. Surgery is still indicated for recurrent massive bleeding or a progressive infiltrate around the fungus ball.
Right, embolization first.
Yes. For candid infections, prompt removal of all central venous catheters is crucial. Candida mediastinitis, an infection in the central chest, has a high mortality rate and requires surgical debridement in addition to prolonged antifungals. Histoplasmosis, a common fungal infection, can form an asymptomatic solitary nodule called a histoplasmoma, which usually needs no treatment. A rare complication is bronchiolitis, where calcified lymph nodes erode into a bronchus, causing cough and hemoptysis, which can be life-threatening if it leads to massive bleeding. Another severe uncommon manifestation is fibrosing mediastinitis, where chronic inflammation causes dense scarring that can compress major veins or the esophagus with no definitive cure. Coccidioidomycosis, or valley fever, affects about 40% of those who inhale its spores, causing flu-like symptoms. Most cases are self-limited. Blastomyces dermatitis, found in soil, can cause chronic pulmonary or disseminated disease with non-specific symptoms resembling chronic pneumonia.
One of the most frightening symptoms is coughing up blood. What defines massive hemoptysis, and how do doctors approach such an emergency?
Coughing up blood or hemoptysis can indeed be terrifying. To understand massive hemoptysis, it's helpful to know about the lungs' blood supply. The lungs have two main systems: the pulmonary arterial system, which is low pressure, and the bronchial arterial system, which operates under high systemic pressures. Most massive hemoptysis originates from the bronchial circulation, where hyperplastic tortuous arteries can bleed heavily.
Okay.
Causes are numerous, ranging from common infections like bronchitis or bronchiectasis to more serious issues like tuberculosis, lung abscesses, fungal infections like aspergilloma, lung cancer, or even trauma. Hemoptysis from lung cancer itself is usually mild. Massive bleeding from lung cancer is rare and often signals a terminal event. The definition of massive hemoptysis is pragmatic: any degree of bleeding that threatens respiratory stability. So the clinical judgment of respiratory compromise is the crucial first step. We approach it in two main scenarios. Scenario 1, significant, persistent, but non-massive bleeding. The patient is bleeding briskly, but can still clear blood and secretions. Immediate steps include ICU admission, strict bed rest with the bleeding side down, oxygen, cough suppression, and large IVs. Mild sedation, aerosolized adrenaline, antibiotics, and correcting any blood clotting issues are also part of the plan. If compromise seems imminent, we secure the airway with a breathing tube and perform flexible bronchoscopy to localize the bleeding, which may lead to a procedure called bronchial artery embolization or, if appropriate, surgery. Scenario 2, significant, persistent, and massive bleeding. This is life-threatening and requires immediate emergency airway control and preparation for potential surgery. These patients are best managed in an operating room equipped for rigid bronchoscopy. Immediate intubation for ventilation and suctioning is crucial. Rigid bronchoscopy allows for adequate suctioning and clear visualization. We can also use it to ensure the non-bleeding lung is ventilated. Ice saline lavage of the bleeding site can stop bleeding in up to 90% of patients. Bronchial artery embolization is a key intervention. If a rigid bronchoscope is unavailable, a balloon catheter can be used to temporarily block the bleeding bronchus via a flexible bronchoscope. Surgical intervention for massive hemoptysis is usually performed after the patient is stabilized. Immediate surgery is needed in less than 10% of cases due to the overwhelming bleeding. In such emergencies, after localizing the bleeding with a rigid bronchoscope, immediate open surgery is performed. Treatment is highly individualized based on the source, patient condition, and lung reserve. Urgent surgery is indicated for bleeding from cavitary disease or fungus balls, where rebleeding is likely, or for bleeding due to pulmonary artery erosion.
For some patients with severe emphysema, there's a specialized surgery called lung volume reduction surgery. How does it work, and for whom is it indicated?
Lung volume reduction surgery, or LVRS, is a specialized procedure for severe emphysema. The ideal patient has what we call heterogeneous emphysema with apical predominance, meaning the worst diseased areas are clearly seen on CT scans in the upper parts of the lungs, and these areas show minimal function on specialized scans.
Okay, so it's targeted.
Exactly. The mechanism of LVRS involves surgically removing these non-functional, severely emphysematous areas. Think of it as pruning an overgrown bush. Theoretically, this reduces lung volume, which then restores more favorable respiratory mechanics. By removing the hyperinflated diseased lung tissue, it improves the position and function of the diaphragm and can also reduce dynamic small airway collapse in the remaining healthier lung.
Right.
Outcomes from the landmark National Emphysema Treatment Trial, NET, were significant. In carefully selected patients, LVRS significantly improved exercise capacity, lung function, quality of life, and dyspnea compared to medical therapy. However, these functional improvements tended to decline after 2 years. Importantly, LVRS was associated with increased short-term morbidity and mortality, and it did not confer an overall survival benefit compared to medical therapy. So patient selection is absolutely critical.
When the lungs are truly failing, transplantation becomes the ultimate option. What are the key considerations here?
Lung transplantation is indeed the ultimate option for end-stage lung disease. The most common indications are chronic obstructive pulmonary disease, COPD, and idiopathic pulmonary fibrosis, IPF.
Okay.
Regarding the types of transplant, most patients with IPF and older patients with COPD are offered a single lung transplant. Younger COPD patients and almost all patients with primary pulmonary hypertension or cystic fibrosis are typically offered a bilateral lung transplant. Heart-lung transplant is reserved for patients with irreversible heart failure combined with lung disease. Donor criteria have been liberalized in an effort to expand the donor pool, as waiting list mortality is about 10%. Lungs may now be used from donors with a smoking history or those older than 50 years in special circumstances. The use of 2 living donors, each donating a single lower lobe, is also a strategy to increase the donor pool, with similar recipient outcomes to cadaver donors. Most of the early mortality after lung transplant is related to primary graft failure, which is a severe ischemia-reperfusion injury to the transplanted lung. The most significant impediment to longer-term survival after lung transplant is the development of bronchiolitis obliterans syndrome, BOS, which is a manifestation of chronic rejection. Episodes of acute rejection are major risk factors for developing BOS, as are conditions like chronic gastroesophageal reflux disease.
Moving to the bony framework around the lungs, the chest wall, what's the initial approach to a mass in this area?
When a patient presents with a chest wall mass, it's critical for surgeons to understand that their approach to diagnosis and treatment will significantly impact the patient's survival and tumor control. The initial evaluation involves both laboratory tests and imaging. For imaging, both CT and MRI are utilized. MRI is often preferred for preoperative planning because it provides multiple planes of imaging and better delineates the relationship between the tumor and surrounding muscle, neurovascular structures, or the spine. This can enhance the ability to distinguish between benign and malignant sarcomas.
Biopsy is a critical first step, but surgery isn't always the first choice for diagnosis, especially with the risk of spreading cells. How is that managed?
You're right. Obtaining a tissue diagnosis is the very first step for any chest wall tumor. However, inappropriate or misguided open biopsy techniques carry the potential to seed surrounding tissues and even the pleural space if the lesion turns out to be a sarcoma. So, careful management is essential.
Okay.
Tissue diagnosis is typically accomplished using one of 3 methods. 1, needle biopsy, often the first choice, performed under CT guidance as a fine needle aspiration, FNA, or a core biopsy. Pathologists can accurately diagnose about 90% of sarcomas this way. The major advantage is it avoids contaminating the wound or body cavity. 2, incisional biopsy. If a needle biopsy isn't diagnostic, an open incisional biopsy might be done, but the incision must be placed directly over the mass and oriented so it can be completely removed later during the definitive surgery. Drains are generally avoided to prevent spread. 3, excisional biopsy. This is reserved for very small lesions, less than 2.0 lineators, or when imaging strongly suggests the lesion is benign, or if it has the classic appearance of a chondrosarcoma, where definitive surgical resection can follow immediately.
Not all chest wall masses are malignant, thankfully. What are some of the common benign ones, and how are they treated?
That's a good point. Thankfully, many chest wall masses are benign. Let's cover a few key types. 1. Chondroma. Common in children and young adults, usually at the front of the ribs. They are painless masses that can grow quite large. Treatment involves surgical resection, but for larger ones, a wider margin is used because they can sometimes harbor a low-grade chondrosarcoma. 2. Fibrous dysplasia. Often found in young adults, typically in the back of the rib cage. It presents as an expansile mass with thinning bone. Local excision is curative. 3. Osteochondroma. The most common benign bone tumor found in younger individuals, often near growth plates. These can be part of a hereditary syndrome, which increases the risk of them turning into chondrosarcomas. Any new pain or growth needs careful evaluation. Local excision is usually sufficient for benign ones. 4. Eosinophilic granuloma, benign bone-destroying lesions found in children. They can cause pain and tenderness and sometimes resemble more serious tumors. Limited surgical resection is the usual treatment.
Desmoid tumors are an interesting case. They're not malignant but can be locally aggressive. What makes them so challenging?
Desmoid tumors are indeed fascinating. They're benign fibrous tumors, but their defining characteristic is their locally aggressive nature. Patients typically present with pain or a fixed mass on the chest wall. While they don't metastasize, they have a significant propensity for local recurrence, even after complete initial resection. This high recurrence rate is because they microscopically infiltrate surrounding muscle and soft tissues.
Right, that infiltration.
Exactly. Because these lesions have low cellularity, needle biopsy often doesn't yield enough cells for diagnosis, so an open incisional biopsy is frequently necessary for larger lesions, following strict rules for incision placement. Surgery involves a wide local excision with a 2-4 centimeter margin. An intraoperative frozen section assessment of these margins is crucial. This often requires removing the involved ribs and one rib above and below. While survival after complete excision is excellent, about 90% at 10 years, the challenge lies in achieving those clear margins given their infiltrative nature.
Sarcomas are the primary malignant tumors of the chest wall. What defines them, and how are they treated given their aggressive nature?
Malignant tumors of the chest wall are primarily either metastatic lesions or sarcomas. Soft tissue sarcomas of the chest wall tend to have significantly worse survival rates compared to similar tumors located in the extremities, even if they present as localized disease. All sarcomas also have a propensity to spread to the lungs.
Okay.
The primary features impacting the prognosis and treatment of sarcomas are their histologic grade and their responsiveness to chemotherapy. Preoperative or neoadjuvant chemotherapy is often used. It offers several benefits. It allows assessment of the tumor's sensitivity to chemotherapy, and it can improve resectability by shrinking the tumor, potentially making a previously unresectable tumor amenable to surgery. Tumors that respond well to preoperative chemotherapy generally have a much better prognosis. Treatment algorithms for sarcomas are complex and depend on the tumor's response to chemo, the patient's physiological state, and the presence of metastatic disease. Initial treatment options often involve preoperative chemotherapy followed by surgery, and then postoperative chemotherapy, particularly for aggressive types like osteosarcoma or Ewing sarcoma. For others, primary surgical resection and reconstruction might be the first step. If the tumor involves underlying lung or diaphragm, an en-bloc resection, removing it all in one piece, is often required to achieve clear margins.
Okay.
Let's touch on two specific sarcomas. Chondrosarcoma is the most common primary chest wall malignancy. They typically arise from the front of the ribs and show characteristic stippled calcifications on CT scans. They are slow-growing, low-grade, and painful. Treatment is a wide surgical resection, usually 4 centimeters, after ruling out lung or bone metastases. They are generally not sensitive to radiation or chemotherapy. Osteosarcoma, while common bone malignancy overall, represents a smaller percentage of chest wall tumors. In young adults, they are rapidly enlarging, painful masses. They have a high propensity to spread to the lungs. They are sensitive to chemotherapy, so preoperative chemotherapy is commonly used, followed by complete surgical resection with wide margins.
If a large part of the chest wall needs to be removed, how is that reconstructed to protect the vital organs inside and ensure stability?
Reconstructing large chest wall defects is complex, requiring careful preoperative planning and close collaboration between thoracic and plastic surgeons to achieve optimal physiologic and cosmetic results. The reconstruction is ideally performed during the same operation as the tumor resection. The primary goal of reconstruction is to prevent lung herniation and provide stability for the chest wall. For larger defects, robust materials are needed. The current preference leans towards a 2 mm polytetrafluoroethylene, or Gore-Tex, patch, or a double-layer polypropylene, or Marlex, mesh, sandwiched with methyl methacrylate. Gore-Tex is favored because it's impervious to fluid, preventing fluid buildup and minimizing infection, and it provides excellent rigidity and stability when secured taut to the surrounding bone. Except for very small lesions, adequate tissue coverage for these reconstructions necessitates the use of myocutaneous flaps, which are muscle and skin flaps often harvested from muscles like the latissimus dorsi or pectoralis major.
Now let's venture into the mediastinum, the central compartment of the chest nestled between the lungs. How is this complex area organized, and why is that important for understanding potential conditions?
The mediastinum is indeed a complex area, conventionally divided into compartments for easier classification of its anatomic components and disease processes, despite some natural overlap. The most common scheme is the three-compartment model. 1. The anterior compartment. This lies between the sternum and the heart-great vessels. It often contains the thymus gland, lymph nodes, and sometimes parts of the thyroid or parathyroid glands. 2. The visceral or middle compartment. Located between the great vessels and the trachea, this compartment is home to vital structures such as the heart, great vessels, aorta, pulmonary arteries, veins, SVC, trachea, esophagus, and major lymph nodes.
Right.
3. The posterior compartment. This lies behind the other compartments, including the areas next to the spine. It typically houses nerves, the thoracic duct, and lymph nodes.
Okay.
This compartmentalization is crucial because certain types of masses or pathologies tend to occur more frequently in specific compartments, which helps guide diagnosis.
What clues do doctors look for when someone has a mediastinal mass? Do symptoms vary by age or type of mass?
Mediastinal pathology varies significantly with patient age. In children, neurogenic tumors in the posterior mediastinum are most common, while in adults, the most common include neurogenic tumors in the posterior compartment, benign cysts, and thymomas in the anterior mediastinum. About 25% of mediastinal tumors are malignant in both age groups.
Okay.
Interestingly, up to 2/3 of mediastinal tumors in adults are discovered incidentally, meaning they're found on scans ordered for unrelated problems. However, when symptomatic, these tumors are significantly more likely to be malignant. Symptoms often arise from a mass effect, where large tumors or cysts compress vital mediastinal structures. The trachea is a common target, leading to symptoms like a persistent cough, shortness of breath, or stridor, a high-pitched breathing sound. Chest pain or dyspnea may also be reported due to associated fluid around the lung or heart or nerve involvement. Occasionally, a mediastinal mass can be discovered during a workup for hoarseness if it's compressing the recurrent laryngeal nerve. Systemic symptoms like night sweats, weight loss, and fatigue can also provide clues, especially in lymphoproliferative disorders like lymphoma.
Imaging is crucial here, even for incidental findings. What tools are used and for what specific purposes, especially if an endocrine origin is suspected?
Imaging is indeed vital. CT scans are the standard for initial evaluation of mediastinal masses. Contrast-enhanced CT is preferred as it significantly improves the distinction of soft tissue structures from blood vessels.
Right.
MRI offers distinct advantages, particularly when there's concern for invasion of major blood vessels or spinal involvement, as it provides more accurate and detailed imaging. MRI is also preferred over CT if the patient has an allergy to iodine contrast.
Okay.
If an endocrine origin is suspected, specialized imaging becomes available. A thyroid scan helps identify intrathoracic goiters. Octreotide scan or MBDG scans are helpful for neuroendocrine tumors like pheochromocytomas. A sestamivi scan is useful for precisely localizing a mediastinal parathyroid gland. PET scans can help distinguish malignant from benign tumors by detecting increased metabolic activity, but their routine role in staging surgically resectable lesions is not yet fully established.
Can blood tests help diagnose these masses, or are they mainly for confirming what imaging already suggests?
Blood tests or serum markers can be invaluable in certain situations, sometimes even guiding treatment before a biopsy. For example, for germ cell tumors, specific serum markers are key. In non-seminomatous germ cell tumors, either alpha-fetoprotein, AFP, or human chorionic gonadotropin, HCG levels will be elevated. If these levels are very high, it's almost 100% specific for this type of tumor, and some centers will even start chemotherapy based on this without biopsy. For seminomas, AFP is always normal, and HCG is only slightly elevated in some cases. This clear difference helps distinguish these types.
Okay, that's very useful.
Yes, for parathyroid adenomas, particularly if located in the mediastinum, measuring intact parathyroid hormone is extremely useful. It aids in diagnosis and is also used during surgery to confirm complete removal, as the hormone level should rapidly normalize.
Biopsy is often needed, but surgery isn't always the first step for diagnosis. What are the non-surgical biopsy methods for mediastinal masses?
That's right. For mediastinal masses, many are ultimately managed non-surgically. So obtaining an adequate tissue diagnosis through the least invasive approach is essential. The primary methods for diagnostic non-surgical biopsies include CT-guided needle biopsy. This uses CT imaging to precisely guide a needle into the mass to obtain a tissue sample. ABS-guided FNA, endobronchial ultrasound-guided fine needle aspiration. This technique uses an ultrasound probe on a bronchoscope to visualize and then biopsy masses and lymph nodes adjacent to the airways.
Right.
EUS-guided FNA, endoscopic ultrasound-guided fine needle aspiration, similar to EBS, but uses an endoscope through the esophagus to access masses and lymph nodes near the esophagus. Core needle biopsy. This can also be performed under CT or EUS guidance to obtain a larger tissue sample than an FNA, useful for certain diagnoses.
Okay.
It's crucial to discuss with the pathologist beforehand what type of histologic assessment, special stains, and markers are needed for an accurate diagnosis, especially for complex cases like lymphomas.
And if those non-surgical biopsies aren't enough, what are the surgical biopsy options?
If non-surgical biopsies are inconclusive or not feasible, surgical biopsies are employed. Mediastinoscopy is a common approach, particularly useful for masses in the paratracheal region, which are easily accessed. For tumors located in the anterior or posterior mediastinum, a VATS, video-assisted thoracoscopic surgery approach, either from the left or right side, often allows for safe and adequate surgical biopsies. In specific cases, such as an anterior tumor or one with significant peristernal extension, an anterior mediastinotomy, also known as a Chamberlain procedure, may be the ideal surgical approach for biopsy.
Thymomas are the most common tumors in the anterior mediastinum for adults. What should we know about them, especially their intriguing association with myasthenia gravis?
Thymomas are indeed the most frequently encountered neoplasm in the anterior mediastinum in adults. One of their most striking features is their strong association with myasthenia gravis, MG, an autoimmune disorder. Between 10% and 50% of thymoma patients will have MG symptoms or antibodies. Conversely, less than 10% of MG patients actually have a thymoma. While thymectomy removal of the thymus gland can improve MG symptoms in some thymoma patients, it has a more significant impact on MG patients without a thymoma, with many achieving remission or improvement.
Interesting difference.
Yes. About 5% of thymoma patients can also have other perineoplastic syndromes, like red cell aplasia. Large thymic tumors can also present with mass effect symptoms, such as cough, chest pain, or superior vena cava syndrome due to compression. Diagnosis is often suspected based on CT, but confirmed after surgical resection, as pre-surgical needle biopsy can be challenging. CT scans can help distinguish thymomas from lymphomas, as thymomas typically appear as a solitary encapsulated mass. PET scans may help differentiate thymoma from thymic cancer. Treatment is primarily complete surgical removal, which is definitive. Local recurrence and survival depend on the tumor stage. VATS, minimally invasive, is feasible in experienced centers if complete resection without capsule disruption can be ensured. Otherwise, traditional open surgery through a median sternotomy is used. Even advanced tumors with local invasion of resectable structures like the heart lining or major vessels are considered for resection, often with reconstruction. A multidisciplinary approach is mandatory for advanced lesions. Adjuvant radiation or chemotherapy may be used, especially for invasive or incompletely resected tumors.
These tumors grow along nerves. What are the main types and their implications, especially if they extend into the spinal canal?
Nerve sheath tumors account for about 20% of all mediastinal tumors. Over 95% of these are benign neuralmomas or neurofibromas, while malignant neurosarcomas are much less common. Neuralmoma, also known as schwannoma, arises from Schwann cells within nerves. They are generally benign, firm, and well encapsulated. If a CT scan suggests the tumor extends into the intervertebral foramen, MRI is used to evaluate this dumbbell configuration, which can lead to spinal cord compression and paralysis, requiring a more complex surgical approach. Resection is recommended, and VATS is often safe and effective. Small, asymptomatic tumors can be observed in older or high-risk patients. In children, however, all neurogenic tumors are typically resected due to a higher incidence of malignant types.
Right, different approach for kids.
Neurofibroma consists of both nerve sheath and nerve cells. Up to 40% of patients with mediastinal neurofibromas also have generalized neurofibromatosis, von Recklinghausen's disease. While most are benign, malignant degeneration to neurofibrosarcoma occurs in 25–30% of patients, with the risk increasing with age and previous radiation exposure. Neurofibrosarcomas carry a poor prognosis due to rapid growth and aggressive local invasion. Complete surgical resection is the mainstay of treatment.
Another type is ganglion cell tumors.
Among ganglion cell tumors, ganglion neuroblastoma contains a mixture of benign ganglion cells and malignant neuroblasts. These tumors are encapsulated and occur most frequently in infants and children younger than 3 years old. The majority are resectable, with an 80% 5-year survival rate.
These are rare but can cause significant issues due to hormone production. What are paraganglionic tumors?
Paraganglionic tumors arising in the chest include chemodectomas and pheochromocytomas. Intrathoracic pheochromocytomas are extremely rare, and about 10% are malignant. They can be problematic because they can produce catecholamines, leading to life-threatening high blood pressure. Diagnosis is confirmed by measuring elevated levels of urinary catecholamines. Preoperative care is crucial, involving medications to block the effects of these hormones to prevent intraoperative complications. These tumors are highly vascular and require a careful surgical approach.
Lymphoma is a very common cancer, and it can originate in the mediastinum. What should we know about its mediastinal presentation?
Lymphoma is the most common malignancy of the mediastinum. In about 50% of patients with both Hodgkin's and non-Hodgkin's lymphoma, the mediastinum can be the primary site. The anterior compartment is most commonly involved. The good news is that chemotherapy, often combined with radiation, yields high cure rates, up to 90% for early-stage Hodgkin's disease and up to 60% for more advanced stages.
Another rare but important group, especially in young men, are germ cell tumors. Where do they come from, and what types are found in the mediastinum?
Mediastinal germ cell tumors are uncommon, but are the most common malignancy in young men, typically between 15 and 35 years of age. While most germ cell tumors originate in the gonads, primary mediastinal germ cell tumors are thought to originate from misplaced pluripotent germ cells during embryonic development in the mediastinum.
Okay.
About 1/3 of all primary mediastinal germ cell tumors are seminomatous, and the remaining 2/3 are either non-seminomatous tumors or teratomas. Their treatment and prognosis vary considerably. For diagnosis, mature teratomas, benign, often have characteristic CT findings with combinations of fluid, soft tissue, calcium, and/or fat. Seminomas usually have normal serum markers, AFP, HCG, while non-seminomatous tumors often have high levels of these markers. If diagnosis is uncertain, a biopsy is required. For treatment, non-seminomatous germ cell tumors are often bulky and can invade adjacent structures. Chemotherapy is the preferred initial treatment, followed by surgical resection of any residual disease. Survival rates are reasonable with this approach. A critical caution: oxygen toxicity can occur in patients treated with bleomycin, a common chemo drug, so high levels of oxygen must be avoided during surgery due to risk of respiratory failure.
Wow, important detail.
Absolutely. Teratomas are the most common type of mediastinal germ cell tumor and can contain tissues from 2 or 3 embryonic layers, for example, teeth, hair, cartilage. Mature benign teratomas are cured by surgical resection. Rarely, a teratoma can contain a focus of carcinoma, which is locally aggressive and responds poorly to chemotherapy.
Cysts are fluid-filled sacs that can appear in the mediastinum. What types are common, and how are they managed?
Benign cysts account for up to 25% of mediastinal masses and are most frequently found in the middle compartment. A CT scan showing characteristic features, like near water density in a typical location, is almost 100% diagnostic. Let's look at the common types. 1. Pericardial cysts, usually asymptomatic, discovered incidentally at the right base of the heart. For most simple asymptomatic cysts, observation is recommended. Surgery or aspiration may be indicated for complex or large symptomatic ones. 2. Bronchogenic cysts. These are developmental anomalies from abnormal budding of the foregut, most often located behind the carina where the trachea splits. They are thin-walled and contain mucoid material. Many are found incidentally in adults, but many eventually become symptomatic with chest pain, cough, or dyspnea. If large, typically over 6 centimeters, or symptomatic, resection is generally recommended due to risk of complications.
Right.
3. Phemic cysts, generally asymptomatic and incidental. Simple cysts are typically of no consequence, but occasionally a cystic neoplasm needs to be ruled out. 4. Ectopic endocrine glands. Up to 5% of mediastinal masses can be of thyroid origin, usual extensions of neck goiters. About 10–20% of abnormal parathyroid glands are found in the mediastinum. Surgical resection is indicated, often guided by CT or sestamibi scans.
Inflammation or infection of the mediastinum can be very serious. What are the acute and chronic forms, and how are they treated?
Mediastinitis, inflammation or infection of the mediastinum, is indeed a very serious condition. Acute mediastinitis is a fulminant infectious process that rapidly spreads along the fascial planes. It's a true surgical emergency. Etiology, most commonly caused by esophageal perforations for medical procedures or spontaneous rupture, deep sternal wound infections after heart surgery, or severe neck infections. Clinical signs, symptoms. Patients typically present with fever, severe chest pain, difficulty swallowing, respiratory distress, and crepitus, a crackling sensation under the skin in the neck or upper chest. They can rapidly deteriorate to sepsis and shock.
Okay, very serious.
Diagnosis, management. A chest CT scan is crucial to determine the extent of spread and guide surgical drainage. Immediate treatment involves correcting the primary problem, for example, repairing esophageal perforation, and aggressive debridement and drainage of the infection. Antibiotics and supportive measures are critical. Chronic mediastinitis, also known as sclerosing or fibrosing mediastinitis, results from chronic mediastinal inflammation, most frequently due to granulomatous infections like histoplasmosis or tuberculosis. Pathophysiology. Chronic low-grade inflammation leads to widespread fibrosis and scarring. This dense scar tissue can entrap and compress low-pressure veins, like the superior vena cava, the esophagus, and even the pulmonary arteries, leading to significant symptoms like SVC syndrome, swelling in face neck, or difficulty swallowing. Treatment. There is no definitive treatment. Surgery is indicated only for diagnosis or in specific patients to relieve airway or esophageal obstruction or to achieve vascular reconstruction. Less invasive procedures like dilation and stenting of airways or the SVC have shown promising palliative success.
Finally, let's look at the pleura, the lining of the lungs and chest cavity. What does this anatomy tell us about common conditions?
The pleura is a critical anatomical structure. Each side of the chest has a mesothelial lining that covers the lung, the visceral pleura, and lines the rib cage, mediastinum, and diaphragm, the parietal pleura. Between these two surfaces is a potential pleural space, normally occupied by only a thin layer of lubricating fluid. The parietal pleura is extensively innervated by nerves. This is why irritation of this outer lining from inflammation, tumor, or trauma leads to the sharp localized sensation of chest wall pain. In contrast, the visceral pleura, which covers the lung itself, has no pain nerves, so direct injury to the lung surface typically doesn't cause sharp chest pain.
A common finding is a pleural effusion, or fluid buildup. What causes this, and when is it concerning?
A pleural effusion refers to any significant collection of fluid within the pleural space. Normally, fluid continuously enters and is absorbed, but any disturbance in this balance can lead to accumulation. Common causes include congestive heart failure, bacterial pneumonia, malignancy, pulmonary emboli, and viral diseases.
Okay.
For access and drainage of pleural fluid, most patients with effusions of unknown cause should undergo thoracentesis, which is drawing fluid with a needle. Exceptions are clear-cut cases like heart failure, where a trial of diuretics might resolve it. If the effusion is large and compromising breathing, or if there's suspicion of empyema, pus in the pleural space, early and aggressive drainage, possibly with surgery, is needed.
Right.
For small, free-flowing effusions, an outpatient diagnostic thoracentesis is performed. The fluid's appearance is informative. Clear, straw-colored fluid is often transitive, low protein from fluid imbalances like heart failure, while turbid or bloody fluid is often exudative, protein-rich from inflammation or tumor invasion. Grossly bloody effusions without trauma are frequently malignant. For loculated effusions trapped by adhesions, CT or ultrasound-guided drainage is indicated. A small-bore catheter might be inserted. For cases requiring biopsy or interventions like pleurodesis to stick the lung to the chest wall, minimally invasive VATS may be used. Chest tube insertion involves making an incision and bluntly penetrating the pleura, guiding the tube to an optimal position to drain air or fluid. Complications can include injury to adjacent organs like the lung, liver, or spleen, or bleeding.
How do doctors determine the type of fluid they're dealing with? That must be crucial for guiding diagnosis and treatment.
Determining the type of fluid is absolutely crucial. We differentiate between transudates and exudates, primarily based on their protein and LDH lactate dehydrogenase content, along with the clinical context. Transudates are typically clear and have low protein and LDH levels. They result from imbalances in osmotic or hydrostatic pressures, common in conditions like congestive heart failure or cirrhosis. Think of it as fluid leaking out due to pressure problems, not inflammation.
Okay.
Exudates, on the other hand, are protein-rich with high LDH levels. They can appear turbid, bloody, or purulent and arise from inflammation or direct pleural invasion by a tumor. To definitively differentiate, we use Light's criteria, which involves specific ratios of protein and LDH in the pleural fluid compared to blood serum. If the criteria suggest a transudate, we focus on underlying systemic conditions. If it's an exudate, further diagnostic studies are needed.
Got it. Light's criteria.
Yes. These further studies include cell counts. For example, high neutrophils for acute inflammation, high mononuclear cells for chronic issues like cancer or TB, Gram stains and cultures for bacteria, and glucose levels, often decreased in complex infections or malignant effusions. This fluid analysis helps, but the ultimate decision for prolonged drainage or surgery depends on the effusion size, how well it drains, and whether the lung can re-expand.
Right.
A pleural effusion accompanied by chest pain, coughing up blood, or shortness of breath out of proportion to the fluid size should immediately raise concern for a pulmonary embolism, PE. These effusions can be transudative or exudative. Diagnosis often involves a spiral CT scan, and a negative D-dimer test can help rule out PE.
What about effusions caused by cancer? How are those managed, especially for patients with end-stage disease?
Malignant pleural effusions, MPE, are a common finding in cancer patients. The primary sites of origin vary by sex. Lung cancer is the commonest cause in males, while breast cancer is most frequent in females. Lymphoma and GI cancers can also cause them. Management of MPE is highly influenced by the effusion size, the degree of associated dyspnea, and crucially, the patient's prognosis and the lung's ability to re-expand. Sometimes, effusions associated with NSCLC are benign, allowing for surgical resection of the tumor. For symptomatic, moderate to large effusions, there are several management options. 1. Tunneled indwelling pleural catheter. This is the primary indication when poor lung expansion, due to entrapment by tumor or adhesions, predicts a poor result with pleurodesis. These catheters have dramatically changed the management of end-stage cancer, allowing for outpatient management and substantially shortening hospital time.
That's a big improvement.
Definitely. 2. Tube thoracostomy with sclerosing agent installation. This is preferred if the lung is expected to fully expand and the patient has a longer life expectancy. Sclerosing agents like talc or doxycycline are instilled to induce inflammation and scar tissue, obliterating the pleural space. Talc has the highest success rates, 60–90%. 3. VATS with talc installation. This minimally invasive surgical approach is typically chosen for patients with good performance status and a longer life expectancy, especially when the effusion is free-flowing and the lung can fully expand.
Empyema sounds like a serious infection. How does pus accumulate in the pleural space, and what's the treatment from early stages to complex cases?
Empyema is defined as a purulent pleural effusion, a collection of pus in the pleural space. Its frequency is increased in older or debilitated patients. It's often a complication of pneumonia, but can also occur after surgery, trauma, or from GI infections. Organisms typically enter the pleural cavity from adjacent infections or direct contamination, for example, from a needle stick. When organisms enter, there's an influx of white blood cells and fluid, leading to inflammation and accumulation of fluid. Empyema progresses through stages. Early stage, exudative. The initial fluid is watery. At this point, treatment might be antibiotics alone or a chest tube for drainage. Fibrinopurulent stage. Over hours to days, the fluid thickens and becomes loculated with fibrinous adhesions forming. A chest tube or thoracoscopy is needed to remove the fluid and adhesions and help the lung expand. Organizing stage. This is the most advanced stage where a thick pleural rind develops, trapping the lung. Complete lung decortication peeling away this rind is necessary, usually by thoracoscopy or open thoracotomy, to allow the lung to reinflate.
Got it. 3 stages.
The microbiology is diverse, often polymicrobial. Antibiotic choice is guided by cultures. Recently, intrapleural fibrinolytic therapy, a combination of TPA and enase, has shown promise in trials. Given through the chest tube, this combination reduces fluid viscosity and helps clear the pleural space, reducing hospital stays and surgical referrals. If there's a residual space after drainage, persistent infection is likely. Early thoracic surgical consultation, complete drainage, and lung reinflation are crucial to avoid chronic problems.
Chylothorax, a leak of lymphatic fluid into the chest, sounds unusual. What causes it, and how is it diagnosed and treated?
Chylothorax is indeed unusual, involving the accumulation of chyle, which is lymphatic fluid, in the pleural space. Its etiology is most commonly surgical trauma to the thoracic duct, or a major branch, for example, during esophageal or neck surgery. It can also result from non-surgical trauma or diseases affecting the mediastinal lymphatic system. To understand its pathophysiology, you need to know about the thoracic duct. This is the body's largest lymphatic vessel, originating in the abdomen and ascending through the chest, transporting fat absorbed from the digestive system, along with protein and lymphatic material. It carries a high volume of chyle, and significant injuries can cause leaks exceeding 2 liters per day. If left untreated, this can lead to severe protein, lymphocyte, and fluid depletion, causing serious metabolic effects and, ultimately, death.
Wow.
Diagnosis is usually suggested by thoracentesis, which reveals milky, non-purulent pleural fluid. However, if the patient is fasting, the fluid may not look milky. Lab analysis is key, showing the presence of chylomicrons, a high lymphocyte count, and very high triglyceride levels. A triglyceride level greater than 110 mg/dL is highly accurate for diagnosing chylothorax. Management depends on the cause and drainage amount. Initial conservative management usually involves chest tube drainage, keeping the patient NPO, nothing by mouth, and providing total parenteral nutrition, TPN, to bypass the digestive system. In centers with interventional radiology expertise, thoracic duct embolization should be considered early. Surgical ligation or embolization is recommended if significant chyle drainage continues despite conservative measures, typically over 500 ml a day in adults. Untreated chylothorax has a high mortality rate, but with early recognition and aggressive management, the mortality rate is now less than 10%.
Finally, let's explore primary tumors of the pleura, including the infamous mesothelioma. How do these differ, and how are they diagnosed and treated?
The most common type of primary tumor of the pleura is malignant mesothelioma, with approximately 3,000 new cases per year in the United States. Others include benign and malignant fibrous tumors of the pleura, lipomas, and cysts. For malignant mesothelioma, the only known risk factor is asbestos exposure, identified in over 50% of cases. Exposure is typically work-related, common in industries like shipbuilding. It's important to note that while asbestos and smoking synergistically increase lung cancer risk, smoking does not increase the risk for malignant mesothelioma. There's a long latency period, at least 20 years, between asbestos exposure and the development of mesothelioma. The tumor typically grows as multiple pleural-based nodules that coalesce into sheets, spreading rapidly over the pleural surfaces and invading surrounding structures. Distant metastases are common. Most patients present with shortness of breath and chest pain. Over 90% have a pleural effusion, but thoracentesis, fluid tap, is diagnostic in less than 10% of patients. Often, a thoracoscopy or open pleural biopsy with special stains is required to differentiate mesothelioma from adenocarcinomas, which can look similar. Key to differentiation is immunohistochemistry, using specific markers to identify cell origins. Fibrous tumors of the pleura are distinct and unrelated to asbestos exposure or malignant mesotheliomas. They generally occur as a single, often pedunculated mass arising from the outer lung lining. They can grow quite large and are often discovered incidentally on chest x-rays, usually without a pleural effusion. They can be either benign or malignant. Malignant tumors are differentiated by features like high cellularity, rapid cell division, and necrosis. Symptoms like cough, chest pain, and shortness of breath are more common in malignant tumors. They can also be associated with paraneoplastic syndromes like low blood sugar or hypertrophic pulmonary osteoarthropathy. For both benign and malignant types, symptoms typically resolve with surgical resection, and complete removal can be curative, especially for benign ones. However, incompletely resected malignant tumors may recur locally or metastasize, with more than 50% of patients dying from the disease. #outro.
We've journeyed through the incredible complexity of the thoracic cavity, from the delicate and specific vascular supply of the trachea to the multifaceted world of lung cancer with its intricate classifications and diverse presentations, and the critical conditions affecting the chest wall, mediastinum, and pleura. We truly aim to go deep to give you the insights needed to feel like an elite professional in understanding this material.
If we connect this to the bigger picture, what stands out to me is the sheer dedication to precise diagnosis, individualized treatment planning, and the constant evolution of surgical and medical techniques. This entire field always puts the patient's functional status and quality of life at the forefront. It profoundly underscores how every detail, every classification, and every piece of anatomical and pathological knowledge truly matters in clinical outcomes, dictating the very path a patient's care will take.
This raises an important question for all of us. As medical technology advances and our ability to detect and treat these conditions becomes ever more refined, How might our understanding of early disease and curative treatment continue to shift, blurring the lines of what we once thought possible? What new breakthroughs will this foundational knowledge lead to next, and how will it continue to redefine human health?